This is the demonstration of a coblation assisted tonsillectomy, that is an extracapsular tonsillectomy for the indications of recurrent tonsillitis as well as sleep disordered breathing. As we can see here, the first step is using the coblation device. We are using a Extra HP wand, and the first incision using the wand happens at the junction or at the lateral border of the tonsil that differentiates it from the anterior pillar. One thing to wonder always is that this wand, the face of the wand, should always face medially towards the tonsil and not towards the tonsillar bed, because that is not the place for a dissection. We are doing this under microscopic control for better vision. As you see, the first point is to use the coblation wand on ablation mode and to define the correct plane of the tonsillectomy, the plane between the lymphoid tissue of the tonsil and the connective tissue, while taking care not to unnecessarily expose or ablate the musculature inside the tonsillar bed. So, here one can initially show some patience and spend some time in identifying the right plane, because once the right plane is identified, the rest of the surgery becomes much more sorted and straightforward. Most part of the surgery is conducted using the ablation mode of the coblation device. However, in case of some bleeding, one can easily switch to the coagulation mode as well. Now, as we have dissected the superior pole partially, you can see that most of the musculature is spared, and we are carefully dissecting the lymphoid tissue from the connective tissue of the tonsillar bed. As we keep dissecting using the coblation device, we keep exerting a medial pull on the tonsil with a Dennis Brown tonsil holding forceps, and as you see here, sometimes a slight bleeding can be encountered with small vessels being exposed, and once that is seen, they can be safely coagulated using the coagulation mode of the coblation device before resorting to further dissection. Now, post the superior part of dissection, we take our coblation device and the dissection inferiorly. As you can see here, there is slight amount of bleeding, and which can be safely coagulated very easily using the same device without switching to a bipolar cautery or something else. Some amount of muscle may be exposed during this surgery. However, it is best that that exposure is limited to minimal, and that helps us in reducing the post-operative pain and expedition of early and fast healing. As you can see there, we are right on the surface of tonsils, the lymphoid tissue. Sometimes if the patient has had recent episodes of tonsillitis, this plane can have some extra vascularity, and if that be so, this surface, which is going to be removed any which ways, can also be safely coagulated without any worries or any addition of pain, because most of this oozing is happening from the portion of the tonsil that is going to be excised any which ways. Post this, we will use the coblation wand in gentle brushing strokes, again making the coblation wand face medially towards the tonsillar surface and not on the tonsillar bed. As one can see, the slightest amount of muscular exposure is visible, but we can always try to keep that in check and highly limited, and to help, again as I said, in healing as well as reducing post-operative pain. Now, as we keep dissecting towards the lower part of tonsil, that is where a slight amount of caution and patience is also important. Here, one of the assistant can gently retract the anterior pillar laterally to be able to see if there is any small bleeder present, which can be taken care of before we proceed further inferiorly. The tonsillar artery or its branches often come at the inferior pole of tonsils. So, here one needs to be more judicious as well as patient in using the ablation and the coagulation mode both turn by turn, so as to first coagulate along the surface and then ablate, so as to not cause any alarming hemorrhage from the tonsillar bed. As we keep going inferiorly, this is a large tonsil, as you can see that, and inferiorly we would encounter the junction of the palatine tonsil with the lingual tonsil, and one must differentiate that and not go inside the lingual tonsil because that will cause unnecessary excessive pain. Here, as you can see, since there was slight amount of bleeding, we have resorted to more gentle brushes on the coblation device and not going too aggressively, and again going onto the medial aspect of the tonsil and not damaging or ablating the musculature in the tonsillar bed. Once again, the point is to spare the lingual tonsil and not cause any injury or ablation injury towards the base of tongue. Hence, the device must again point medially. At each point of time, we keep suctioning the fluid from the oropharynx. And like you see here, we are selectively using first the coagulation mode from the along the entire inferior part of the tonsil to be able to safely coagulate the vessels, the branches of tonsillar artery that supply the tonsil, followed by the ablation. As you see again, a small bleeder was there which was easily coagulated using the coagulation mode. So, the coblation tonsillectomy helps us in managing the entire procedure using a single device, and bleeding sometimes, if a little, can easily be managed using the same device without resorting to any other equipment. As you can see here, the inferior most pedicle of the attachment is still there, and once again, assuming that may contain some branches of tonsillar artery, we keep using the coagulation as well as the ablation device, as well as avoid going too laterally on towards the tonsillolingual region, because that would incite more pain. The slightest amount of oozing or bleeding can be managed using the coagulation mode, and as you see, a small tongue of tonsillar tissue is still left inferiorly, which can again be safely and easily held and removed using the same coblation device, carefully again avoiding any excess ablation laterally on towards the tonsillar bed, because that surely can induce more pain and often incite episodes of secondary hemorrhage. And as we keep medial traction on the tongue of remnant tonsillar tissue, the same coblation device can very easily and elegantly remove this excess tissue. This could have been removed using ablating it from medial surface as well, but since there was a sufficient tissue, we could hold it using a forceps and get it out of the fossa. As you see here, there is a fairly good preservation of the anterior and posterior pillar. There is no bleeding anywhere to be seen. Slightest amount of exposure of the muscle on the posterior pillar is evident, but that's not so much and should not lead to any significant excessive pain.